All right, well, hello and welcome to the Lunch and Learn series for TeleSpecialists. Good morning, good afternoon, depending on where you're located. I know that our reach is all over the country. Thanks so much for joining today. Thank you so much for your time. My name is Raina Gupta. I am a neurologist and sleep medicine specialist, and I am the medical director of the sleep medicine service line at TeleSpecialists. So today I'm really excited to talk about sleep medicine and to take you into a new world. As many of you are probably very familiar with our neurology and stroke talk so far. Also, we'll be taking questions at the end. Please feel free to type in a question in the Q&A section, and we'll try to get to as many as we can. My talk itself is about 30 minutes, and then we'll have plenty of time for discussion or for questions. So thanks again for joining, and let's go ahead and get started. Okay, our objectives today. So the things I wanted to talk about, the things I wanted to really better understand include the importance of sleep, sleep abnormalities, and our health, the pathophysiology, effects, screening tools, treatment options for obstructive sleep apnea, to better understand a polysomnogram, which is a sleep study or a sleep test. Kind of what is it? What does it look like? What are the numbers that we need to know, especially when we get sleep study reports? When and who to refer to sleep medicine, and the use of telemedicine for sleep patients. All right, good. So let's start with why is sleep important? And I'm sure any of us that have had a few terrible nights of sleep in a row know how sleep affects every part of our life, every part of our world. So I want to go through a few of the general reasons why sleep is important, and then, of course, the opposite of poor sleep is also going to be at play. Let's start with memory. Memory. We know that sleep is vital for the processing and storage of short to long-term memories. We're going to talk more about memory later in the later slides. Also, concentration. Good sleep contributes to improved reaction time. And of course, this can be important regarding motor vehicle crashes and safety outcomes. We'll talk about that also later in the slides. Cognition. Improved alertness and concentration can be a result of good sleep. And of course, productivity. Better complex reasoning and logical thought, better innovative and creative thinking can also come from good sleep. Tissue repair. We know that good sleep contributes to increased blood flow, hormones to promote wound healing, tissue repair, and to reduce inflammation. Immunity. White blood cells and cytokines are produced and released during sleep. Growth. Human growth hormone is released during slow wave sleep, and this is when children grow. Hormones, synthesis and secretion, really throughout our lives, many of the hormones are created during sleep and even released, especially during puberty, but throughout our whole lives. Another few reasons why sleep is so important: calorie regulation. This has been a significant area of interest in weight gain, weight loss, and we're going to talk a little bit about the hormones implicated in calories and in weight. We know that we can consume fewer calories, secondary to hormones responsible for appetite. Athletic performance. This is another area of research and interest, especially for professional athletes, as their goal is to optimize their sleep and optimize their performance. We know that good sleep can contribute to increased intensity, energy, coordination, speed, and mental function. Fertility. We know that good sleep can contribute to lower evening cortisol levels. And the opposite is also true. Poor sleep can contribute to higher evening cortisol levels. And then mood stability. So now we get into the data and the numbers and the studies of why sleep is important. Now, we know that good sleep is important for all the reasons we discussed, but poor sleep, how does poor sleep affect our health? Most of the studies and the data that we know about poor sleep is based on studies in obstructive sleep apnea. So, this acronym that you see, OSA, stands for obstructive sleep apnea. And I'll define it later, but I'll just give you a quick glimpse. So, obstructive sleep apnea is defined as abnormalities in breathing during sleep that can have a consequence to them. So, they either disturb our sleep or they decrease the oxygen saturation in our blood or both. So we're going to go through kind of the studies in poor sleep as it relates to sleep apnea, where the data is very robust. We know that the effects of snoring and sleep apnea are many, and they include cardiac problems, stroke, of course, depression, high blood pressure, increased insulin resistance, death, increased traffic and workplace accidents, hormone disruption, memory problems, and snoring. So first, I want to go through sleep apnea and stroke. So this is the kind of data heavy, numbers heavy part, and really is just to demonstrate what we know about how sleep apnea, obstructive sleep apnea, is a risk factor for all of these health consequences or health diseases. So in a cross-sectional analysis of more than 6,000 patients in a study that's well known called a sleep heart health study, we found that the overall risk of prevalent stroke was 1.58 among patients with sleep apnea. And in parentheses, we have this definition, and I'll just explain what this means. So the AHI is another acronym that is important to understand. It stands for Apnea Hypopnea Index, which just means the number of abnormal breathing events someone has per hour. And I'll define this again later in the slides, so you don't have to remember it. But it's one of the important numbers that sometimes patients will tell you, oh, I had this many numbers per hour, or that you'll see in the sleep studies. So in this study, they were studying apnea hypopnea index 11, greater than 11, which means that they have to have at least mild or higher sleep apnea, mild, moderate, or severe sleep apnea. So the risk of stroke is so much higher in mild, moderate, or severe sleep apnea than in patients that don't have. A 10-year follow-up of data of patients with stroke showed an increased risk of death in those patients with sleep apnea, independent of all other risk factors. So yes, there's increased risk of stroke, increased risk of death. Another study on stroke, and this is important because this tells us that there's a difference between mild sleep apnea and moderate to severe sleep apnea. So inside of sleep apnea, of course, just like any health condition, there's mild, moderate, and severe, and there's a big difference in clinical implication. So that's what this study demonstrates, and that's why I wanted to just discuss it with you. In a cross-sectional study of Japanese men, brain MRI revealed silent brain infarct in 25% of patients with moderate to severe sleep apnea, obstructive sleep apnea. So 25%, so a fourth of patients with sleep apnea might have had a silent stroke, which I guess would be without clinical manifestation. And they saw it in only 8% of patients with mild sleep apnea and 6% in control. So control without any symptoms of sleep apnea, without diagnosis of sleep apnea. So significant difference, 1/4, 25% versus 8%, meaning there's a difference between severity inside of sleep apnea, mild versus moderate to severe. Okay, so let's talk about sleep apnea as a risk factor in cardiovascular disease. We know that there are many implications of sleep apnea and cardiovascular disease, including coronary artery disease, atrial fibrillation, and arrhythmias in general, stroke, which we just spoke about, hypertension, congestive heart failure, and pulmonary hypertension, which often lean more towards central sleep apnea. So let's break these down a little bit more. And why do these happen? Why does sleep apnea create a risk factor for cardiac abnormalities? So these are really the known reasons. So one is sleep apnea, obstructive sleep apnea, there's that OSA again, can cause autonomic dysfunction, can cause increased levels of plasma and urine catecholamines, and can cause non-dipping blood pressure. So what is non-dipping blood pressure? I just want to define this real quick. So when we sleep, our blood pressure is supposed to go into the relaxed, restful state, as is our brain and our body in general. And often that means it goes lower, as does our heart rate. So the blood pressure dips during sleep, and that's a normal part of our physiology. But if a patient has sleep apnea, meaning if they have disruptions in their breathing while they're sleeping, then their blood pressure doesn't get to dip, doesn't get to go into this low restorative state. It actually becomes higher than it should be during sleep. And this is often related to the sympathetic activity or sympathetic surge as it relates to sleep apnea. So the blood pressure doesn't get low. The heart, of course, is going to be affected because it's working harder. And so are the other risk factors, or so are the other health conditions that we're going to talk about. Also, sleep apnea may have different impacts on men and women. We found that women with sleep apnea can have higher troponin T levels, increased left ventricular mass index, increased risk of heart failure and death. And then the next slide, I'm going to talk about hypertension. So hypertension, of course, can be a root cause of a lot of these problems, including heart problems, including stroke, etc. So this is really important, and I'm sure we all of the providers here, and even all the public knows that there are plenty of people with hypertension, and so this is important to look for and to know about to be able to screen in our hypertensive patients. So about half of sleep apnea patients have hypertension, and about 30% of patients with hypertension have sleep apnea. And often it's not diagnosed. So this is an important correlation that I want you guys to take away from this, that it's so common in hypertension. And of course, hypertension can cause all kinds of other problems. But it's important to screen in our hypertensive patients, especially that are not well controlled, or that we keep increasing their meds and we don't know why. And we're looking for other risk factors. There's this study, again, this Wisconsin sleep cohort, that showed a blunted or absent nocturnal blood pressure decline. That's what we just talked about, that non-dipping blood pressure. As well as effects on sleep apnea on hypertension may be evident in middle age as opposed to older subjects. So could there be a difference in middle age versus older in sleep apnea's impact on our general health? Maybe there is, and maybe that gives us a significantly increased risk of some of these health issues in a middle-aged person as opposed to what would naturally happen in an older age person if they have sleep apnea. And we already talked about sleep apnea can raise systolic blood pressure. So then the next question, of course, is, okay, so I'm screening my patients for sleep apnea that have high blood pressure, or my high blood pressure patients, or my sleep apnea patients, I'm putting them on treatment. What should I expect to happen? Do I magically get normal blood pressure all of a sudden because that's the only contributing factor, or what do we expect? And actually, there has been some clinical evidence of improvement in blood pressure and systolic blood pressure with treatment of sleep apnea. And so this is the numbers that I want you to know about. So effective treatment of sleep apnea by CPAP, and we'll talk a little bit more, I'll define CPAP, but it's one of the treatment modalities, has been shown to markedly and acutely decrease blood pressure and sympathetic traffic during sleep. So we talked a little bit about the sympathetic surge. So what's happening in sleep apnea? And we'll define it after we get through all these studies and data. But because the sympathetic surge happens, if we can lower the surge and treat the sleep apnea, we would expect a reduction of systolic blood pressure of 3.4 millimeters mercury to 12.6 millimeters mercury. I usually tell my patients to expect 3 to 5 millimeters mercury drop in systolic blood pressure, and we see it, and probably you guys have seen it also once they're treated and once they are on sort of their body has adapted to the treatment. It's pretty robust, but it can be significant. Okay, so let's move on from hypertension to coronary artery disease. Again, there's a lot of studies, a lot of data, but I want to present it to you. And then we'll get out of it into the fun part. So coronary artery disease, we know that the prevalence of sleep-disordered breathing in coronary artery disease patients has been shown to be up to twofold greater than in non-coronary artery disease subjects. So do these people have significant risk of coronary artery disease, MI, stroke? Of course, and twofold, like That's significant. So that's important. Another important thing to look for in our patients that have MI, that have stents, to go back and say, oh, have you been screened for sleep apnea? Do we need to look for it? Do you carry risk factors? And we'll talk about those risk factors as well. Okay, hope everyone's with me. I'm just speeding through. Okay, so nocturnal arrhythmias. We talked a little bit about the strain on the heart, the impact on the heart. And we know that up to half of sleep apnea patients can have nocturnal arrhythmias. The most common ones are non-sustained VTAC, sinus arrest, second-degree AV conduction block, and PVCs. I want to talk more about atrial fibrillation. So sleep apnea is strikingly more prevalent in patients with AFib than in high-risk patients with multiple other cardiovascular disease. It's so common in AFib patients, and developing AFib is so common in sleep apnea patients. There's a study of 312 patients in a cardiology clinic, and they found sleep apnea in 49% of atrial fibrillation patients and 32% of general cardiology patients. So yeah, it can happen in the general population. It's pretty common in cardiology patients, and it's very common in atrial fibrillation patients, maybe 1 out of 2. So this is a common referral source for us as cardiologists, especially cardiologists when patients are newly diagnosed with atrial fibrillation or there's suspicion of atrial fibrillation, or the cardiologist wants to do a procedure to treat the atrial fibrillation, a cardioversion or an ablation. That's a very common time where the cardiologist will say, you need to see the sleep doctor, let's check this out, and this is why. So sleep apnea is associated with recurrent AFib after cardioversion. So if you're the cardiologist and you say, I want my procedure, my ablation, my cardioversion to be successful as possible, and this patient maybe has risk factors for sleep apnea, let's check them out and treat them, because the risk of them going back into AFib is so much higher if they have untreated sleep apnea than if they don't. And this is the data to support that. In a pool of patients post-cardioversion for AFib, 82% of previously diagnosed untreated sleep apnea patients had recurrence of AFib within a year, within 12 months, as opposed to 42% in the treated sleep apnea group, and the control group was 53%. So significantly more patients after having this procedure, which is, a lot to go through, may have to have it again or may not be successful. Okay, so let's move on to insulin and how this impacts the endocrine system. Insulin sensitivity. We know that decreased glucose tolerance and decreased insulin sensitivity can result from sleep restriction. Less insulin is released with sleep loss, which can result in higher glucose levels with decreased slow wave sleep. We also just briefly touched on fertility, and increased evening concentrations of cortisol can happen in sleep apnea patients, which is linked to infertility. Okay, so this is memory. This is the first thing we mentioned in the importance of sleep. And we know that obstructive sleep apnea, untreated, can be a risk factor for dementia or mild cognitive impairment. Deposits of beta amyloid begin to appear in the brains of patients up to 10 years prior to symptomatic onset of Alzheimer's disease. Beta amyloid is reduced during sleep by the glymphatic system. When this does not occur properly, beta amyloid can build up and cause plaques, which are characteristic of Alzheimer's disease. So this means we need good sleep to clear out some of the plaques that build up over time in our brains. And if we don't have good sleep, this process is not going to be optimized. This is a safety outcome slide. So this is motor vehicle crashes. In a study of firefighters, 6,933 firefighters, they were evaluated with screening tools to see if any of them had sleep disorders. And we found that 37% did have sleep disorders, more than a third. That's a lot of firefighters with sleep disorders. So the most common one was sleep apnea, 28.4%, insomnia, 6%, shift work disorder, and restless leg syndrome. Sleep and health, weight. So we talked a little bit about calorie consumption in the beginning and how this has become sort of an area of interest for general well-being, but also weight gain and weight loss. We know that chronic partial sleep loss may increase the risk of weight gain and obesity. So they say in order to maintain a healthy weight, you need to sleep enough. You need to sleep the amount that you should for your body. So the two hormones that we found that are implicated in weight are ghrelin and leptin. And you might have heard of these, but if you haven't, you'll probably hear about them. Ghrelin gets increased in poor sleep, and ghrelin is the hunger hormone released from the stomach. Leptin is decreased in poor sleep, and leptin is the satiety hormone, the hormone that says, I'm full, I don't need to eat extra or eat again, second helping, etc. And these, if they're abnormal, they can increase hunger and appetite with sleep loss. We've found that bedtime extension in short sleepers may prevent weight gain or facilitate weight loss. And we've also found that avoiding sleep deprivation may help to prevent obesity, especially in children. So although there are lots of tools that we're trying to implement in children to prevent childhood obesity, this is another one, and to make sure that they're sleeping enough and how that can play a factor in these hormone levels and their eating is very important and something to recognize in children, in all of our children, but also with pediatricians talking to patients about sleep. Okay, so let's talk about mood. This is the last category of health that I wanted to discuss. We know that depression is more common among people who sleep less than 7 hours nightly. So getting adequate sleep can improve mood stability. People with insomnia may show signs of depression and anxiety more than the general population. And sleep deprivation can worsen anxiety, creating a negative cycle of sleep issues. And of course, this does become a cycle. So I don't sleep well. I get nervous about my sleep. I put more emphasis on my sleep, and then I can't sleep, and then it becomes a vicious cycle. And it takes some time and some effort, often, to break that cycle. And we've all had some sleepless nights, insomnia for whatever reason, but a lot of people have it frequently, and of course, it impacts all of the things that we're talking about. We also know that people with sleep apnea have higher rates of mental health problems, including depression, anxiety, and panic disorder. Okay, so I'm just going to take a second to make sure everyone catches up, takes a breath, and if you're asleep, wake up, and we got a little bit more. Okay, so we're going to transition into what is sleep disordered breathing. I want to go through sleep apnea. I want to define it. I want you to understand it and kind of what is important. So now we know what's important about sleep, how poor sleep can impact our health. So let's go into the details of sleep apnea. So sleep disordered breathing includes abnormal respiratory patterns during sleep. There are a couple different names of things that you might hear, names of disorders. So the first one is upper airway resistance syndrome. This is basically the precursor to sleep apnea. So it means that you're having a couple abnormal respiratory events during sleep, but they don't qualify for sleep apnea. Some people use this, some people don't. You might hear it around sleep studies. The next is obstructive sleep apnea, and we're going to talk about that in a lot of detail. Central sleep apnea. Then the two that are less common, obesity, hypoventilation syndrome, which is also known as Pickwickian syndrome, and mixed obstructive and central sleep apnea. Okay, so this is the pathophysiology. What's happening in obstructive sleep apnea and central sleep apnea? How are they different? Why do we care about them? So let's talk about these. So this is obstructive sleep apnea. This is central. These are a couple different categories. There's oronasal airflow, respiratory effort, and oxygen saturations. So what's happening, the mechanism of obstructive sleep apnea, and it's just that, it's a descriptive word, it's obstructive. There's an upper airway obstruction where the airflow stops. The body is still trying to do the work of breathing. So the chest and the abdomen are still breathing, still moving as if they're breathing because they're trying to do the work of breathing. Now, when the upper airway obstructs, we get a lack of airflow. So the oronasal airflow stops. Then the body is still trying to breathe. And meanwhile, because the airflow is blocked, the oxygen is going to slowly go down. So there you get the oxygen desaturation. Now, if someone was to observe this, and often what we see is somebody will describe these events as choking episodes, gasping episodes. Patients will make snoring, snorting sounds. They'll snore themselves awake. A lot of patients don't even know that these are happening, that these events are happening during their sleep because we're asleep. How would we know? Sometimes patients wake up frequently and don't know why. Sometimes patients feel tired or sleepy during the day. Sometimes patients feel like they wake up to use the restroom like 4 times at night, even if they don't really need to go. So there's a lot of different descriptions of these events, but they're actually pretty scary if you witness it, or if your patient's family member witnesses it, or if their friends or whatever witness it, they'll be concerned about it usually. So let's talk about the difference between obstructive and central sleep apnea. So central sleep apnea is really that there is no breath triggered from the brain. So the central nervous system doesn't trigger a breath, meaning that there's no airflow and there's no work of breathing. The body's not trying to breathe because it didn't get a trigger of airflow. The oxygen will dip, the oxygen saturations will dip as expected, but it's a totally different mechanism and it's treated differently. Okay, so this is the formal definition of obstructive sleep apnea. Obstructive sleep apnea is a sleep-related breathing disorder that involves 3 different events. One is a respiratory effort-related arousal. The second is called a hypopnea, which is considered a decrease in airflow. I think of it as hypo is small, so a small change in airflow, or a complete cessation of airflow, which is an apnea. And that's the one we just saw, where there's no airflow. Airflow is completely blocked. Despite an ongoing effort to breathe. So this is the anatomy of what's happening in sleep apnea. This patient is sleeping supine on their back, and you can see the anatomy. This is the nasal airflow coming in here. This is the oral airflow. This is the tongue. Who knew it was so big, right? And we're getting the tongue collapsing. The tongue and the upper airway structures are collapsing and blocking off airflow. And of course, gravity has something to do with this. That's why supine sleep is often worse or more significant sleep apnea symptoms in a lot of people as compared to lateral or stomach sleep. But I think this is a really cool way to really see what's happening. So history of suggestive of sleep apnea. So what are your patients going to be telling you? What things can you ask them? Like, hey, have you had experienced this? If you find that your patient had a stroke or has high blood pressure that's difficult to control, or any of these health issues, you can ask them, how's your sleep? How are you sleeping? Are you feeling tired during the day? Are you sleepy during the day? Do you wake up frequently? And a lot of times it'll come out. Patients will just go ahead and talk about it. And a lot of the patients I see, I often ask, have you ever had a sleep study or been told that you have sleep apnea? And it's not uncommon that patients say, yeah, but I'm not treating it, or I'm not using whatever they gave me. So that's a good way to kind of go back into it and say, let's look at this again. So here's some of the history things that you'll notice. So nocturnal choking episodes, witnessed apneas, of course, if there's somebody else that sees them, excessive daytime sleepiness, cardiovascular disease, like we talked about, cerebrovascular disease, headaches, not just morning headaches, but even migraine headaches. It's pretty common for patients to get severe headaches or chronic headaches from sleep apnea. Here are some risk factors. So what are the risk factors related to sleep apnea that are modifiable and not modifiable? So yeah, we can do something about these. Obesity. So one of the things we look for in our patients is body mass index. So we know a body mass index of 30 or greater is a risk factor for sleep apnea. Alcohol intake, which fragments our sleep. Smoking, supine body position. So we talked about the difference between sleeping on your back versus sleeping on your side. And some people, as a way to self-treat, don't sleep on their back. And there are a lot of devices that teach people or prompt patients to not sleep on their back for this reason. Nasal congestion or obstruction. Of course, if your nasal airway is obstructed, you're going to get less airflow. Non-modifiable risk factors, gender, which I guess is sort of modifiable, race, ethnicity, age, menopause, and craniofacial anomalies. So what is the real prevalence? Like, how many people out there have sleep apnea in your patient population or in general? There are a lot of studies that look for prevalence, and there's a significant difference, but really it's 9 to 24% of middle-aged adults have AHI more than 5, which is defined as sleep apnea. That's a lot. That's 1 in 10. That's like 1 in any meeting or group or gathering or anything in your waiting room. Probably one of those people has sleep apnea. And 49% of middle-aged adults have apnea-hypopnea index more than 15. So more than 15 is moderate sleep apnea, and I'll show you these numbers in a little bit more detail. So this, of course, is being undiagnosed in a lot of people. And we know that 70 to 80% of patients with moderate to severe sleep apnea have not been clinically diagnosed or treated. And these subjects did have access to healthcare. So we can't blame it on we didn't have healthcare. So that's a lot, meaning it's important for us to have awareness, to maybe talk to patients, talk to people about it, and see if we can screen and treat more effectively. All right, so now we get to talk about sleep studies, sleep tests. So polysomnogram is really just a fancy word for a sleep test. And I want to go through the different kinds that you might hear about and kind of what are they for. So a diagnostic polysomnogram is really just what the whole night we have all the leads, and I'll show you a sample of a polysomnogram. We have all the leads and we want to better understand the sleep without changing anything. Without treating anything, is just to understand what's going on with the sleep. Another type of polysomnogram is a split night, and really is just that we're splitting the night between diagnostic data and potential treatment data. And so this really depends on how we order the study, as the first 2 hours, at least 2 hours, if not more, will be pure diagnostic, meaning there's no treatment or intervention. And the second half of the night or the rest of the night can be therapeutic or titration to find out that if they have sleep apnea, yes, we found it during the diagnostic part, and we treat it, how effectively are we treating it, and kind of what are the outcomes, what do the numbers look like when we treat. The next type is a titration study. So there's no diagnostic data. It's just, let me put the treatment modality on you and let's see how you do and what pressures or what your needs are. Where should we set the treatment modalities? And there's actually one kind I left off on titration. So there's CPAP, BiPAP, and I'm going to explain what these are. And there's also oral appliance titration. And I'll talk a little bit about oral appliance later, but these are different kinds of studies. Another type of study is a multiple sleep latency test. This is a daytime nap test. So you get 4 or 5 nap opportunities during the day after a full night of sleep. And the whole goal is to diagnose idiopathic hypersomnia or narcolepsy, to understand, is it too easy for someone to fall asleep during the day at 5 opportunities after sleeping a full night? Or do they fall asleep too fast? Or do they go into dream sleep, which we should not go into so quickly within 20 minutes of a nap? So that's another totally different test. And then, of course, there's a home sleep test, which is not called a polysomnogram. It's called an HST or some version of a home sleep test. Okay, so these are the numbers you need to know. Apnea-hypopnea index stands for, is AHI. And again, it's a number of abnormal breathing events. We briefly talked about what is an apnea, what is a hypopnea, but I'll just state it again. Apnea is full cessation of airflow. There's no airflow, but the work of breathing is still going by the body. Hypopnea is a reduction in airflow. And severe sleep apnea, so apnea-hypopnea index 5 or greater indicates mild sleep apnea. Apnea-hypopnea index of 15 or greater indicates moderate sleep apnea. Apnea-hypopnea index of 30 or greater is severe sleep apnea. So severe sleep apnea is occurring every other minute or more. That is a lot. And of course, it's going to have health implications. And if you think of these patients, sometimes we see these numbers that are really remarkable, 100 per hour, 150 per hour, 60 per hour. It's a lot every minute, maybe abnormality in breathing. And of course, that's going to have some sort of health implications. So when you see the sleep study and you see these numbers, maybe you'll be able to better understand what does it mean and what are the health implications. Okay, so here are the couple, I wanted to just define the PAPs. So PAP is positive airway pressure, and there are a couple different kinds. So these are non-invasive ventilation. These are treatments for sleep apnea, obstructive sleep apnea. CPAP stands for continuous positive airway pressure. It has a pressure capacity, these are measured in centimeters water, of 5 to 20. These can have comfort settings. You don't have to use them. A BiPAP is 2 levels of pressure. So the first is an inspiratory pressure. The second is an expiratory pressure. And the goal of these is to have 2 different pressure settings with a delta, with in between range, so that it enhances gas exchange. These are used for obesity, hypoventilation syndrome, for CHF, for higher pressure needs, and lower oxygen saturations. Of course, oxygen itself can be added to any of these if patients have underlying lung conditions or pulmonary conditions. But a lot of patients with just sleep apnea don't need oxygen along with this because the pressure is what's opening the airway and decreasing the risk of oxygen desaturations. The third kind that we don't hear as much is an adaptive servo ventilator, which is known as ASV. This is really used for complex sleep apnea or mixed sleep apnea, which is obstructive and central at the same time. And these are often on auto mode. The cool thing about these is they can sense the patient's breathing, and they can provide a breath when the brain does not trigger a breath. Okay, so here are some of the treatment options. CPAP and BiPAP therapy are used for mild, moderate, or severe sleep apnea, really any sleep apnea. Oral mandibular advancement device. So I want to describe this in a little bit more detail. This is a mouth guard that's made by a dentist, and the function of it is to advance the mandible to create more space in the back of the throat. These are really only used for mild to moderate sleep apnea, and often patients do well when they have low body mass index, when they don't sleep on their back, when they sleep on their side. And these can have good efficacy in people that don't want to use CPAP, don't need to use CPAP because their numbers are low. But I have a lot of patients that do very well with them. It's just an option. Positional therapy. So positional therapy means if someone has sleep apnea primarily only on their back, supine, we can train them to not sleep on their back or teach them to not sleep on their back. Very expected, intuitive, not anything fancy about it, but it can be very effective in certain patients. Inspire implanted device. So this we get a lot of questions about from patients. Basically, it is a pacemaker that is implanted into the chest with a lead that wraps around the hypoglossal nerve in the throat. And the function of it has a battery inside of it, and it has a remote that you turn it on or off. And what it's doing is it's pushing the tongue, it's protruding the tongue out at like a timed increment, so that it's hoping that when you breathe in and you're sleeping, the tongue will get pushed out and the airway will be open. And there's interesting mixed data about this device, but it's an option. And then there is a trial right now with that's being undergone for medication options for treatment of sleep apnea. I don't have any data, preliminary data of how it's doing, but something to look for in the future. The company that is doing it is called Apnea. Okay, so I want to go through a little bit of the anatomy of obstructive apneas. So this is kind of a subsection of a polysomnogram. So this is the EKG. This is the airflow lead. This is thoracic effort, abdominal effort, and oxygen saturation. So here you see the airflow. This is the inhalation. This is the exhalation. This would be a normal airflow kind of chart. And then you see that the airway obstructs and it becomes flat. And there's no airflow or reduced airflow. In this case, this is an apnea. So the thoracic effort, the body is still trying to breathe. The abdomen is still moving. But what you get is increased effort, and you get paradoxing, meaning they usually move together, but they're trying to force each other to move with so much effort that they start moving opposite. And then here at the end, the airway opens and you get restored airflow. Meanwhile, the oxygen saturations drop and they can go extremely low depending on how long this event persists. Okay, so this is actually a polysomnogram. This is a sleep study. These are the leads that we get. And I think this is kind of cool to see because this is an insider's view. You never really get to see what an epic looks like in a sleep study. These are the EEG leads. So there are at least 6 leads on the head. 2 of them are on the eyes, and the eye leads are to look for REM sleep. There are a couple EMG leads, and this is, of course, an in-lab, so you have to stay overnight. This is not going to be the same as a home sleep test. So there's the chin EMG lead. That's also to look for muscle tone for REM sleep. There's leg EMG leads to look for restless leg movements or abnormal leg movements. There's a snore channel, which is a microphone. There's the airflow channel that we just looked at. There's the nasal pressure transducer. That's the nasal airflow. There's the chest belt and abdomen belt that go on the patient that measure the movements. This is the EKG. This is the oxygen saturation. This is the heart rate. So here, and you see this patient is in stage 2 sleep. And here it transitions to REM sleep. There's that big R, if you can see it. Hope you can see it. This patient is on their back. They're in supine sleep. So there's a lot of data just in one little screenshot. But this is the data that we see during a sleep study. And I want to show you the sleep apnea episode. So here's the hypopnea over here in green, if you can see it. Basically, a reduction in airflow, which with a resultant desaturation, the oxygen drops. Here is an apnea. So this is cessation of airflow. Remember, the airflow is blocked. The body is still trying to breathe. You get that choking sensation with also a decrease in oxygen, another apnea, and another hypopnea. So this is really what it looks like, and it can happen so frequently, a couple a minute even. But it's very dramatic when you get to see it in this fashion. But this is your view of what's happening in a sleep study. All right. So our job really is to screen our patients and to better understand their needs, their health risks, and does sleep apnea play a role? Do we need to send them for screening, and do we need to treat? How do we need to treat? This teddy bear is helps people sleep too. Okay, so when to refer? Really, sleep doctors are happy to see any patient with any sleep problem, easy or complicated. So any patients that you feel need sleep evaluation, testing, or treatment, any patient with risk factors for sleep apnea or health risk factors that we talked about that lead you to look for other risk factors. This happens a lot of times in my stroke and headache patients where I'm looking for what are their risk factors for stroke. And I go through everything. Okay, are you on medications for high blood pressure? Are you on medications for cholesterol? Are you on antiplatelets? Whatever, medications for diabetes. And then I say, hey, have you ever been diagnosed with sleep apnea? Have you ever had a sleep study? And if their answer is no or not on treatment, then hey, let's look at that after we get out of this acute hospitalization, et cetera. Or if you're in clinic, let's go ahead and refer you for that. Also, when the patient needs sleep treatment and management. So do we need to, common question, hey, I've been on the sleep device for years. Do I need to change it? Do I need to update it? Because sleep devices also record data, which is super useful for us because we can see the efficacy of them. Any patient having clinical concern for inadequate sleep and have not had follow-up for over a year, we like to see our patients about once a year, or if something changes like their health status, their medications, their weight, etc. Any complex sleep patient, any patient that you don't feel comfortable seeing or don't understand what's going on. And of course, TeleSleep. So sleep medicine is especially amenable to telemedicine, as really what we're looking for is the history. There are a few things we want to look for in their exam. So one is body mass index, one is neck circumference, as that's a risk factor, and the third is Malampati, which is the airway classification, how much space there is in their airway. And those are really the main things that we look for, meaning we can see them on remotely. Also, their sleep devices can record data, and we can access that and use that to help make decisions about treatment management. All right. So, in summary, adequate sleep, as we know, is important to our vitality, health, and well-being. Poor sleep impacts many factors in our health. It's important to screen for, diagnose, and treat our patients' sleep disorders. Sleep studies are easy to interpret, as you saw, and TeleSleep is on the scene. All right. So I will end it here, and let's see if we can take some questions. Here we go. Is TeleSleep available to private patients versus inpatient or insured? I'm not sure how they're scaling or how they're doing their model. I don't know. I think there's a lot of different formats for TeleSleep. I think TeleSpecialists is launching theirs and sort of open and flexible to the needs of the hospital or the clinic. I think there's a lot of different ways that sleep can be given or done. So I think we're open to that. Maybe have that discussion with the TeleSpecialist groups. Home sleep test versus, that's a great question, versus in-lab sleep test. Okay. So, home sleep tests have kind of showed up in the last few years, and some of it is the payers, the insurance companies, carriers that are asking for home sleep tests. And really, the appropriate patient for a home sleep test would be someone that you sort of screen positive. And there are a couple of screening things that we didn't talk about that can be used, like the Epworth Sleepiness Scale. We can look at those things like health risks, like, oh, they have a history of all of these health issues. They have a neck circumference of X, they have a body mass index of X, they have a Malampati of X, and maybe they have significant risk factors for sleep apnea, so let's do a sleep test. Now, home sleep test can be done, and if the home sleep test is inconclusive, doesn't give enough information, they can always do an in-lab sleep test for a patient that has strong risk factors, or maybe their family members or somebody said, I saw them stop breathing during sleep and I'm concerned. It might be okay to do a home sleep test. There's a lot fewer data points or channels, but it can be available to answer the question of yes, there is sleep apnea, or no, there's not. The variability in the number of events, mild, moderate, or severe, may or may not, be super important. It is in some cases, but I think it's an okay place to start, especially if they're sort of clearly have risk factors and the insurance company asks to do that first. And that's commonly what we see. Insurance company will request that first. In terms of reliability, it varies. Sometimes the data is not good. Patients don't understand how to do it, and then that's okay. We have to do it 1 or 2 nights. The in-lab test is always going to be better as it's done by a technician. So the data is pretty reliable, but it can be used. It's good to know about and a lot easier to do than patients to come in. Medications. That's a good question. Thank you so much for the questions also. Do you recommend any medications as supplement to the CPAP? So in general, if there is sleep apnea and it's obstructive, the CPAP is really gonna fully treat it, and you should get to the apnea-hypopnea index, meaning this number of sleep apnea events should be 0 or 1, which is normal. Usually a normal, healthy person that does not have sleep apnea will still have sleep apnea events, but it's usually like 1 to 3. We don't usually get close to 5, which is sleep apnea. You don't really need any medications. Some patients have difficulty getting used to it. It's a whole new world of, I have to put this on. There are so many different kinds of masks and different versions, but I have to put this on and sleep with it. Some patients can take melatonin to kind of get used to it or get over the anxiety about it. I often ask patients to wear the mask, not connected to anything during the day, to get like habitualized, get used to it when they're watching TV or distracted, so they get used to the sensation of it on their face. But it's so effective that it's really worth trying and getting them accustomed to it however they can. Primary care physicians will manage their sleep patients with the use of ASV. Can you discuss the importance of utilizing a sleep specialist, especially in the presence of cardiac diagnosis and the risks of ASV with these patients? Okay, so ASV is a very specialized machine that is really only useful for mixed sleep apnea and maybe if there's a significant pulmonary abnormality. It shouldn't really be used for general sleep apnea, obstructive sleep apnea, mild or moderate, just like the run of the mill. The most common patient you'll see will have sleep apnea, obstructive sleep apnea. It shouldn't really be used for that. It's really not appropriate. It's a much more expensive and sophisticated machine. In general, they have auto modes, and even the CPAPs have auto modes where you can allow the machine to adjust based on the breathing, so that it has sensors. But the ASV, the really function of it is to give a backup breath or backup rate, meaning if a breath is not triggered, it will give a breath. And ASV has so many functions when you look at the data from it that we rarely use it, only in those very complex patients, and I wouldn't use it for like a general patients for management. I think that when you're looking at some of these disorders, cardiac issues, stroke issues, insulin issues, and there's so many more that we didn't touch on. I think that we want to make sure that the number of sleep apnea events is very low. The other problem that can happen when we don't give the appropriate amount of pressure for the airway. So it's very individualized because my airway and the next person's airway or the next patient's airway might need a different amount of pressure. And it's not always related to weight. Also, there's plenty of people who have just genetically narrow airways that need some treatment for sleep apnea. So you can't really generalize it. I've seen a lot of doctors that are just like CPAP 10, everybody gets CPAP 10. But that doesn't really work. The problem is the physiology of the lungs and pulmonary system is if you give too much pressure. So if I get a higher pressure than I need, then my body will not trigger a breath. So it will induce central events. And so that can also be harmful because you're getting desaturations with that, et cetera. So I think that ASV use should really only be used in those couple complex patients that are going to be really rare. and that either we should use auto CPAPs or have a sleep doctor evaluate and put them on something, and then follow up about once a year. And with telemedicine, it's so much easier because if we can pull the data from the machine and just check in on the patient, any changes in your health and your weight and your um, lifestyle, etc., sleep timing, sleep patterns, the things around sleep, your routines around sleep, I think that's better. Hope that answered the question. Not sure. Not sure if we got it. All right. Any other questions? Well, thanks so much for your time and attention. I really appreciate it. This has hopefully been a little glimpse into the world of sleep and the adventure of it. And I think we can always talk more about it in the future if needed, but we're here if you need us. Let us know. Thank you so much and have a great day.